Okay, very good. Well, you're welcome. I have one more thing for you, Andy. So the compliance appointment. Hey, Brad.
Hello.
How are you?
You too. How are you?
Doing well. How about you?
Good. Good, good.
Excellent. Hey, Leslie.
Hi, Anita.
Thanks for giving the grand rounds today.
Yeah, thanks for inviting me.
Of course. Are you able to screen share and everything? I know people are.
Yeah, I should be. Let me see if I can get that started.
You know, it's dangerous, the VA being so close to Plum Market, because they have vegan cupcakes, and
Oh,
I've been getting them like every day.
you have a lot of yummy stuff at Plum Market. And it's none of it is inexpensive, but it's delicious.
No, yes, yep.
Well, we should, weigh each fellow before and after their rotation there and see if there's a significant difference.
Okay. Here, have a seat wherever you're comfortable.
Looks like I was able to get in. Thank you.
Leslie, we've got most of our fellows here and I think other people are filing in. So whenever you want to get started, I want to make sure you have enough time. Yeah,
Okay.
we're good on this end here.
Okay, great. And this, you're seeing my slides?
Yes, we are.
Okay, excellent. Okay, then I'll just get
Yep,
started.
go for it.
Okay, hi everyone. Well, it's nice to be here today. Thank you so much, Nita, for the invitation to speak at Sleep Grand Rounds. For those of you that don't know me, I'm Leslie Swenson. I'm a clinical psychologist, and I work clinically out of the Behavioral Sleep Medicine Clinic here in psychiatry, and I'm based out of the Sleep and Circadian Research Lab here in psychiatry as well. So I'm excited to talk today about some relatively recent findings from a trial we've completed that I hope is of clinical relevance to you all. So it's a trial looking at treating delayed sleep-wake phase disorder. So that's what I will be speaking about today. And if I can advance my slides. Oh, there it goes. Okay. So I don't have any conflicts of interest to disclose. I will note that the study that I'm speaking about today was funded by the American Academy of Sleep Medicine Foundation, and that I have current funding through the National Institutes of Health. So in terms of what I'll be talking about today, first I'll give you some background and rationale regarding delayed sleep-wake phase disorder and why we need to examine potential treatments for this disorder. And then I'll walk you through the trial that we completed. So as you are familiar, delayed sleep phase disorder is a circadian rhythm disorder. And a core feature of all the circadian rhythm disorders is the disruption in the timing of sleep. That's really a mismatch between our internal circadian clock and the external clock on the wall. And what we see in delayed sleep-wake phase disorder is that the circadian clock is driving the timing of sleep to be much later than conventional or socially required times. So in colloquial terms, we think about someone who has this disorder as a night owl. So someone who prefers to stay up later and sleep into the day and usually gets a second wind in the evening and then feels groggy in the morning hours. So in this disorder, we see difficulty falling asleep and waking up at socially required times. And these are times that are usually required by things like school or work or by social demands like taking children to school or spending time with family or friends. To be diagnosed with delayed sleep-wake phase disorder, we have to see evidence of a 2-hour delay in bed and wake times versus conventional times on a sleep diary or some other method of sleep tracking like actigraphy. We also have to see that when the individual is free to choose their own time in bed schedule, usually this is when they're on vacation or weekends or they have days off, that during these times when they're self-selecting their sleep schedule, they're able to fall asleep quickly, they sleep for a normal amount of time, and then they wake up without too much grogginess. So basically what we're looking for is that their sleep is normal when they can choose when they go to bed and when they wake up. And then we also, in order to meet diagnostic criteria, we have to have these symptoms be present for at least 3 months. So chronic symptoms. And I have this graph here illustrating what sleep looks like in delayed sleep-wake phase disorder. So at the top here, we have the clock time here, and then a normal sleeper who, let's say, is going to bed around 11 and waking up around 7. And this is what sleep looks like for someone with delayed sleep-wake phase disorder when they're free to choose their own sleep schedule or time in bed schedule. They're going to bed quite late, say around 3 a.m., and but they're falling asleep quickly and they're staying asleep for a normal amount of time, and then they're waking up around noon without any sleepiness. And this is different from insomnia in that people with insomnia often have trouble falling asleep or staying asleep no matter when they choose to sleep, whereas someone with delayed sleep-wake phase disorder sleeps without complaint when they're free to choose their own schedule. It's only when they're required to wake up at a certain time for social obligations that they have sleep problems. So when the same person tries to sleep on a schedule that's required by their work, let's say they have to be up at 7 a.m. for work, we see that their clock prevents them from falling asleep until late at night. And then they have a short period of sleep, let's say from 3 to 7, and then they're very groggy for several hours in the morning when their clock wants them to still be sleeping, but they have to be awake for work. So this is the typical sleep pattern that we see in this disorder. So we don't know exactly what causes delayed sleep-wake phase disorder, but there are some likely suspects. So we all have clock genes which regulate our circadian period, and people who naturally have a longer circadian clock period may be more likely to have a delayed sleep-wake phase disorder. It's also possible that people with this disorder have some abnormal sensitivity to light. So maybe they're more sensitive to light in the evening or they're less sensitive to light in the morning. And that's important because light is the biggest external cue to the circadian clocks, and increased sensitivity to light at night or less sensitivity to light in the morning could cause the clock to run later than it would otherwise. It may also be that there's abnormalities in melatonin secretion patterns for these patients. So maybe they have overall less melatonin, maybe their release of melatonin is not timed correctly. And we'll talk more about exogenous melatonin, actually both endogenous and exogenous melatonin later. And then also we know that lifestyle factors can contribute. I certainly think one of the biggest factors in our modern lives to circadian phase delay is the use of electricity in the evening, as well as light emitting devices that we're maybe using too close to bed. So this disorder is more common in adolescents and young adults, which may be due to a normal shift towards a later circadian timing preference that starts in adolescence and lasts into early adulthood. It may also be more common in males than females, as you can see here in this graph, just showing the difference in uh, prevalence rates. That males are more likely to have a later chronotype than females. It's also estimated that as many or more than 10% of the patients that we see in our clinics for insomnia that are presenting with insomnia symptoms actually have delayed sleep-wake phase disorder, which has implications for treatment. And I personally wonder if some proportion of the patients that we treat with CBTI, because we think they have insomnia, actually have delayed sleep-wake phase disorder. And maybe those are the patients that aren't responding to CBTI as well as we might want them to. So as you might imagine and probably encounter with your patients, if you have trouble keeping a sleep schedule that's in sync with the world, there are consequences. And one of the main impacts we see of this disorder is employment challenges. So we see higher rates of absenteeism and presenteeism in patients who have this disorder. And presenteeism is when you're at work, but you're not functioning at capacity. And for these patients, it's because in the morning they're groggy and they are not getting enough sleep chronically. And we also see impairment in social functioning in this disorder because it can be hard for people who are night owls to engage in the social activities that occur during normal waking hours. And it can also strain relationships with family and friends who are awake when the patient is sleeping. And then not surprisingly, we see that quality of life is worse in this population, even when we compare it to other chronic diseases like migraine or depression, that quality of life is pretty significantly impacted by this disorder. So there are various treatment options for delayed sleep-wake phase disorder, including light therapy, prescribed sleep-wake scheduling, prescribed physical activity, and melatonin. Obviously, I'll be talking about melatonin today, but I also want to point out the American Academy of Sleep Medicine clinical practice guidelines. So these are the guidelines for treatment of delayed sleep-wake phase disorder. And as you can see here, like these are the various treatments and then the recommendations for treatment guidelines. And what we see here is that for adults, the only recommended therapy is timed melatonin or melatonin agonists. So there are options, but really the one that is recommended is melatonin. I do want to mention here that, I mean, if you take a look at this table, like there's a lot of no recommendations, and then the evidence that is there is weak. And that's in part because there's a significant lack of research on treatments for this disorder. And the editorial that accompanied the practice guidelines highlighted that there's a real need for field-based studies in delayed sleep-wake phase disorder to study this population in their natural environment, if you will, as opposed to lab-based trials or studies. So in general, there are very few placebo-controlled studies in this disorder, and I would say the existing literature has been limited by small sample sizes, as well as significant variability in the timing of when melatonin is administered across studies. And so that can make it, I think, hard to see a signal. And then I will mention here, we'll talk more about this in just a minute, is that there's lab data that show us that the timing of melatonin is really important. Getting that timing right is important to achieve the most robust circadian advance. And just a few words on melatonin, you all are probably familiar with this. So it's a hormone that's naturally produced in the pineal gland. Among other things, it promotes drowsiness. So in the United States, it's available as a dietary supplement. It's not regulated by the FDA. There's a wide range of doses available, and we most commonly see it used for people who have trouble sleeping. I do want to mention that although melatonin is not regulated by the FDA, interventional research with melatonin requires FDA oversight, which is an investigational new drug application, and that's a pretty intensive process, and that may be one of the reasons why there are fewer studies on this. On melatonin, but it does require a fair amount of legwork to an FDA oversight of the trial if you're going to study it clinically. So we know that exogenous melatonin works by resetting the circadian clock when it's administered at the correct time. So I'm just showing you here a graph that's based on laboratory work done by our colleague here, Helen Burgess, which plots the phase advance curve for melatonin. So here you're seeing the time relative to the sleep midpoint, and then the type of phase shift. So this would be a phase delay, a circadian phase delay, moving someone's circadian clock later. And this would be a phase advance, moving someone's circadian clock earlier. And so remember with night owls, we're aiming to move their clock earlier. So we want to capture this part of the curve. And essentially what we're seeing here is that we see the most robust phase shifting, phase advancing effects of melatonin when it's taken in the late afternoon. So about 5 to 6 hours before usual bedtime, or in this case here on the graph, 9 to 11 hours before the midpoint of sleep. And this study also looked at the different doses of melatonin. So the dashed line is a larger dose, 3 milligrams of melatonin, whereas the solid line is a very small dose, a 0.5 milligram of melatonin. And what you can see here is that the doses have similar phase shifting impacts when you're giving them at the right time. So the tiny dose is as effective as the large dose when you give it at the right time. And this is relevant because if you give someone 3 milligrams of melatonin in the afternoon, they might be falling asleep at 3 or 4 o'clock, which is not something that we want to do clinically. But if you give them the smaller dose, 0.5 milligram, they can take that in the late afternoon, and it's not likely to have soporific effects. And so that's the reason why you'll see in this trial, we used the small dose of melatonin to maximize phase shifting effects while minimizing soporific effects. So in treatment, what we usually do is adjust the timing of melatonin so it's taken earlier every few days as the patient begins to fall asleep earlier. It's often administered in conjunction with time in bed scheduling, which means that the patient's given a specific schedule for when they should get into bed and when they should wake up for the day. And this is also usually adjusted to be earlier every few days until the patient's schedule is where they want it to be. I do want to talk now about how we measure circadian timing, because that is what actually the primary outcome for our trial was, the timing of the circadian clock. So the gold standard measure of the circadian clock is something called dim light melatonin onset. And this is essentially the clock time at which endogenous melatonin production exceeds a threshold. And I'll show you what that looks like in a minute on a graph. But salivary melatonin is the gold standard for estimating circadian timing. I do want to mention that this protocol, the sampling protocol, to measure DILMO accurately, it's a fairly involved protocol, and it does require that the person is compliant with some pretty rigorous instructions. So it's an intensive protocol. The assays are expensive. I should also mention that, which is among other reasons, I'm sure one of the reasons why we don't use it clinically. But essentially you have the person take a saliva sample every 30 to 60 minutes, starting 6 hours before their habitual bedtime. Sorry, 6.5 hours before their, 6 hours. And then you have to have them in dim light starting 6.5 hours before their usual bedtime. And they have to be in dim light throughout the protocol. So less than 50 lux, so really dim light, just enough to see what you're doing, which can be challenging for some people. And usually ahead of time, you have to walk them through ways to cover windows and make sure they're not getting too much light in their environment if you're doing it at home. And then the individual can only be engaging in quiet activities and throughout the protocol, and they have to be seated 10 minutes before each sample because posture can impact melatonin. And then you have to have the person brush their teeth with water prior to each sample to avoid contamination if they've eaten food. So certainly a fairly rigorous protocol to get good data.
Leslie, what are they
Yeah.
doing for 6.5 hours in the dark?
So usually we have people, they can read, they can watch TV, especially if it's on a TV that's like far away from their face.
Oh, I see.
They are allowed to use light emitting devices, provided the light is all the way down, the light level on the device. And we
Yeah.
give them a pair of UVEX, those UVEX glasses, the
Yeah.
orange lenses. So they also have that to wear as well. So at home, that's what they're doing. In the lab here, we have them in red light, and they play card games or things like that, read, it's enough light to read. So they can do things. You don't want them falling asleep, that's for sure, because that would spoil the data. But they can do things. I've done this. I actually did this protocol myself a few months ago, and mostly
Well,
red. But
it sounded like torture the way you said that you could
no,
barely see.
no, yeah.
Oh,
I mean,
yeah.
ideally you can barely see, but you can read and play card games and watch TV.
Good.
So you're not just sitting there staring at the wall.
Leslie, I have a question too. Can you speak to that you said posture makes a difference in terms of the
Yeah, so
melatonin?
I mean, it may be that like if you're standing up and you're walking around because of physical activity feeds into the clock, that could suppress the melatonin. Does that make sense?
Yep, thank you.
Yeah,
Anything here is added with all these stipulations that you're noting, hence the need for real life research.
yes. So this is the end result, and I have one from a patient that I'll show you in a little bit, or a participant in the study. But these are the data that we get in doing the saliva sampling protocol. And what you're seeing here is melatonin levels here on the y-axis, and then the clock time here on the x-axis. And the dark box, let's say, is when this individual is sleeping. So this would be someone who had, we're extrapolating the melatonin sampling across the sleep period. Which you can do, but we don't do that anyway. But you can see here, essentially, usually our protocol would be this window here, which again, you'll see. I'll show you an actual graph from our study in a minute. But what we typically see here is that during the daytime, melatonin levels are really low, and then they start to rise about 90 to 120 minutes before that person's habitual sleep onset time, and then they stay high through the night and then fall. And what we do to determine when that person's timing of melatonin onset occurs is we use a individualized threshold for that person, because some people secrete more melatonin during the day than others. So we essentially take an average of their low daytime points and use that to decide what their threshold will be. So this is the time, this would be this person's DILMO, the time at which their melatonin levels cross their own individualized threshold. So the American Academy of Sleep Medicine Foundation put out a call for applications that evaluate the clinical utility of dim light melatonin onset in the evaluation and management of patients with circadian rhythm sleep-wake disorders. And our group submitted an application asking the question, does timing low-dose melatonin to the patient's individual circadian timing result in better treatment outcomes in this disorder? Which brings us to the Night Owl trial. So this trial was a double-masked randomized controlled parallel trial of 4 weeks of 0.5 milligram of melatonin, plus the behavioral interventions of evening dim light and time in bed scheduling. And participants were randomly assigned to one of two conditions. The first one is the measured DILMO condition, or MDILMO. And in this case, in this condition, the administration of melatonin was timed to the participants' measured DILMO, so to be given 3 hours before their known DILMO. The other group was the estimated DILMO condition, or EDILMO, and in this condition, we estimated their DILMO based on their sleep onset time and had them take the melatonin 5 hours before their sleep onset time. So what we were looking at in the trial, the main outcome or the main aims were to look at the pre to post treatment changes in the circadian timing based on DILMO, and then to look at changes in secondary outcomes. And in both cases, we were anticipating that those participants in the measured DILMO condition would have better outcomes. In terms of the inclusion criteria, I won't really spend too much time on this, but essentially we were looking for adults that met the diagnostic criteria for delayed sleep-wake phase disorder. And in this case, we were looking at sleep diaries and actigraphy for at least 7 days to see that there was a 2-hour or more delay in the timing of their habitual sleep period between their work or school days and their free days. And then in terms of exclusionary criteria, I will mention that with melatonin, again, because this is an FDA monitored trial, we had quite a few conditions that would rule someone out from participating in the study related to medical conditions or medications that can technically interact with melatonin, as well as psychiatric conditions that can influence sleep. And then other things that could influence the clock were exclusionary criteria. And then this is the interventional protocol. So everyone got a 0.5 milligram of melatonin for 28 days. So all participants took melatonin. What was different was that the initial administration time of the melatonin depended on which group they were assigned to. So again, either 3 hours before baseline DOMO or 5 hours before their baseline average sleep onset time. And we used wrist actigraphy to estimate that. And then all participants in the trial had 4 weekly sessions with a psychologist certified in behavioral sleep medicine. So this was Drs. Conroy and Raglan, who you all may be familiar with. They were our interventionists. So they were masked to the condition and did 4 weekly sessions with all of the participants. And everyone had their time in bed schedule initially stabilized to their average time in bed, basically schedule at baseline. So that we stabilized them, and then that time in bed duration was kept the same throughout the protocol. So time in bed wasn't manipulated. And then the initial melatonin time was determined by study staff who are not masked. And then they provided that time to the psychologist. And then with the treatment sessions for everyone, the time in bed schedule, the time of the melatonin could be advanced up to an hour per week until the desired time in bed schedule is reached. And the clinician could use their own judgment to decide week to week how much to shift someone as well. So it wasn't a set 1 hour, but they had up to an hour that they could shift the participant depending on how they were doing. And then everyone was asked to be in dim light and to turn down light emitting devices starting an hour before their scheduled bedtime. So that was an instruction that everyone got as well. And then during the treatment sessions, I do want to mention that the study clinician was provided with actigraphy data, sleep diary data, and then also we were tracking the time at which participants opened the bottle of melatonin. You can, buy research grade trackers that are basically caps that you put on a bottle that will tell you the time at which the bottle was opened. And so we use those as a rough measure of adherence to when the person may have taken the melatonin, so that clinicians received this information before each session. The participants knew that we were tracking all of this information, and then the clinicians would address any adherence issues as they arose to keep the participant on track with respect to their homework and what they were supposed to be doing. So there was A, close follow-up because it was weekly, and B, a good amount of data provided regarding adherence. And this graph just shows you what the treatment might look like. Essentially, what we see here is that 0.5 milligram of melatonin is given 5 hours before the patient's usual bedtime. And then in the next week, these things are moved to be earlier and then earlier until the person gets to the point at which their time in bed schedule is where they want it to be and they're sleeping fairly well. And then we see also this period of dim light scheduled before bedtime. This slide just outlines our outcome measures. The DILMO was our primary outcome measure, but we also looked at other things like sleep, self-reported, objective, behavioral sleep-wake patterns, chronotype, sleep-related impairment, sleep disturbance, sleep quality, and then fatigue during the day. And I just show this so you see what the in-home dim light melatonin onset collection kit looks like. This was made by Dr. Burgess and, oh yeah, Ron.
Well, I'm just curious how you powered this study. It seems like you might need a big sample. And also, were the two clinicians, like, did they know which arm each person was randomized into?
No, the clinicians were masked, so they didn't know which arm, and they were given the time of at which the participant should take the melatonin, but that was determined by study staff. So the clinician did not know. And actually, we looked at their data and they were not good at guessing. It was like 50-50 toss of a coin. So they were not good at guessing what condition they were assigned to. But you're absolutely right about power. And this was meant to be a pilot trial because we didn't have a whole lot of data to inform like what power should be. And so you'll see later, but I mean, ultimately, I think you might need, like you're saying, a lot of people to see a difference in outcomes, which you'll see. That's a spoiler alert, yes. But we had powered it based on basically like clinically significant shift in DILMO, so half an hour would be considered. So that was what we used for thinking of this as a pilot trial. But this is the kit that we send participants home with and I don't actually have the UVEX glasses pictured, but we do send them home with the blue blacking glasses. And this kit contains all the items that the participant needs to complete the in-home collection protocol. They have very detailed checklists as well as an iPod that alarms. It sends out alerts when the participant is supposed to do something, as well as a little bit of text about what it is that they're supposed to do. And then we also do track using the MEMS cap the time at which they open the bottle to take the Salivet to take the sample to make sure that they're taking it at the correct time. I also should mention that Helen is finalizing an app-based version of this kit that would allow researchers to obtain a kit and then just basically the participant just uses an app to walk them through. So it actually consolidates a lot of the materials down. And I tested it out recently. And I think it's really a nice nice step forward in the in-home DILMO collection. So look for that fairly soon. That should be available for researchers doing this kind of work soon. This is an example plot of the DILMO data from one of our participants. So again, what we're seeing here is clock time on the bottom, melatonin level here on the y-axis. And then the blue dots are this person's melatonin during baseline, so pre-treatment. And this was their onset time was about 2200 before they started treatment. And then after treatment, we see here that their DILMO was about 20-30, so almost a 90-minute phase advance, which turned out to be typical for the protocol. But we just see again like this nice advance, this nice movement pulling earlier of the circadian clock time. So the study flow diagram, I won't spend too much time on it, but just let you know that we assessed 75 people. We randomized 40. This trial started before the COVID pandemic, and then continued throughout the COVID pandemic. So there was some recruitment challenges, some bumps in the road related to the research shutdown that occurred, but we randomized 40. We had been aiming for 50, so we fell a little bit short. You can see our allocation here, and then we had a few people drop out for various reasons, and then the data that we used in the analyses. In terms of demographics, I'll just walk you through them here while noting that the only significant difference between groups we observed in demographics was in race, and you can just see what the proportions look like by group here, that was the only difference. And then I do bring up season just because season can influence circadian rhythms. And thankfully, we did not have any differences in season by group. Oh, Nourish.
Hey Leslie,
Hi, Nourish.
I think you mentioned that it's more common in men, but the participants were mostly females. How did-
Yeah. Yeah, I find that I think in general, women tend to participate in research studies more often than men do. That tends to be true across the board, and I think for better or for worse, our study was no exception to that, despite the fact that it tends to be a little bit more common in men than women. Yeah, it's a good point. Yeah, we had like more than half. Yeah, 80%. Well, across, yeah, women. But yeah, women tend to participate in research studies at greater rates than men. We need to find ways to pull more men into our research studies, I think. Okay, so season wasn't different. And then in terms of the analyses, these are intent to treat that I'm presenting. So it includes everyone who started the trial, everyone who had pretreatment data. You'll see that we did t-tests for differences in treatment specific variables, and then linear mixed models to test changes in the outcomes by a condition. And we adjusted significance level for the linear mixed models to be quite low due to multiple testing. And frankly, we had a reviewer on the paper who wanted us to do that. So that's actually the reasons why we did it, but it makes sense. So what you're seeing here is a table showing you the results specific to the treatment variables. And so here I note that the initial scheduled melatonin time, so this is the M-DOMO group, the E-DOMO group, was significantly later in the E-DOMO group. And then we can also, going down here, confirm that the initial melatonin time was scheduled to be on average 3 hours before DOMO time in the M-DOMO group. Whereas for the E-DOMO group, the initial melatonin administration time was actually quite close to their DOMO, it was within an hour on average. But this just kind of confirms that yes, okay, people were told to initially take the melatonin 3 hours before measured DOMO in this group. And in this group, it turns out they were taking it much closer to their actual DOMO. And then what you're seeing here is just the difference between sleep onset time per the actigraphy and the scheduled melatonin time for each week of the study. And actually these were different by group for each week. So this time remained about 6.5 hours, that interval for the M-DOMO group, whereas it averaged around 4.5 to 5 hours for the E-DOMO group. So significantly smaller angle there, phase angle for the E-DOMO group.
Hey, Les,
Hey, Todd.
Dr. Swanson, how are you? Does that second row suggest that the estimations weren't that good? If they were actually taking, if I understood what you said, they were taking on average 49 in the E-DOMO group, 49 minutes before their
Yes.
actual DOMO.
Yes.
So
It
that
turns
suggests that,
yes. Yeah. It
Go
turns
ahead.
out that at least in the sample, estimating DOMO was not very accurate.
Okay.
Yeah.
Yeah.
Based on sleep
Okay.
onset time, which you'll see. I have those data later. They're actually pretty interesting. But yes, our
Interesting. Okay, cool.
estimation paradigm for this group was not correct.
Okay.
And then this is again more of the treatment variable. So the change in scheduled bedtime across the weeks here, change in scheduled wake time, and then the change in scheduled melatonin time. And I just note here that the scheduled wake time was advanced more in the E-DOMO group that first week of treatment, essentially, as was the melatonin time that first week of treatment. So this was different between the groups. And then this slide just shows you the compliance statistics for the trial. I will note that I was pleasantly surprised with how good the compliance was for participants, with both the time at which they were taking the melatonin, as well as compliance with bedtime, rise time. And that might be a reflection of our clinicians doing a nice job of motivating participants to adhere to the protocol, or our participants knowing that we were tracking that very closely. But I would say we had a good adherence across the board, and there were no differences between the groups on any of the compliance measures. So as you recall, our primary outcome is basically the timing of the circadian clock measured by DILMO. And these are the results for DILMO by group. And what you can see here is that in both cases, we had a really nice circadian phase advance with a DILMO change of about 70 minutes in the measured group and almost 2 hours in the estimated group. So really nice phase advance for both groups, and that was not different by group. That was the same. And then these are some of our secondary outcomes, which is fatigue, sleep disturbance, and the sleep-related impairment score. And what you can see here is that both groups improved across time, that wasn't different. And I guess, Naresh, I just want to go back to your chat. Do you mean you think the compliance was better because it was because it was mostly women? Okay, that could be why. I'm sure there's some sex-based difference in conscientiousness in clinical trials for men and women.
Leslie,
Yeah.
you showed, and Todd was asking about it, how with the measured DILMO, the people were taking it right when you wanted them to take it, whereas in
Yeah.
the estimated, they weren't.
Yeah.
And now, when you're showing us the outcomes, it's not quite significant, but the direction of effect, you're saying estimated was better.
Yeah, I mean it's not significant, but you're right. There is a more robust response in the estimated group.
So maybe I'm just asking too early, but I guess you're gonna have the revelatory explanation in the slide coming
Well,
up.
I mean, at the end, I have some explanations for the null findings because technically they're null findings, but I don't have an explanation for why this group may have done a little bit better. I
But
think it's a small sample too.
yes, but in terms of preliminary data for the bigger grant you're gonna write, you're gonna have very different hypotheses going into that one.
Yes, this is true. I think we had very different expectations than what the data showed. Yeah. I
Could
mean,
it be that we don't know really when to administer the melatonin in relation to DILMO?
that could be the case, right? Because there aren't very many existing studies, and the ones that do exist are done in the laboratory under very tightly controlled conditions. And so it may be different. What you do for someone in the home environment may be different. How they respond is different at home than it is when you're putting them in the lab. That could absolutely be the case.
Hmm.
Yeah, but there could also be, we'll talk about it in a minute, but there could also be other aspects of the protocol that influenced the findings beyond the time of melatonin.
Look at that on the right. Okay, it's not significant, you're saying, but
No, these aren't significant by group. Yeah, sleep-related impairment got better for EDOMO.
See, why did you not have any placebo arm in this one?
Because we didn't have a really big budget. It was a small budget, but I do think I wish we had a placebo. I wish we had a placebo. Now, I think that would be important to know. If you're just asking someone to take an inert pill, and then you can separate out the effects of the melatonin versus the behavioral changes, which at this point we can't tease apart. But yeah, it's meant to be pilot small trial. Brad?
Yeah, I just had a question. My understanding is that like light exposure in the morning can also shift your internal clock.
Mhm.
Did you guys control for that, or?
So as you will see in the end, I think one of the reasons for the null findings could be that, remember the EDOMO group had their wake time advanced more quick, like more rapidly or more intensively in that first week. And that could be one of the reasons why. So their wake time was advanced, meaning that they probably got more exposure to morning light than the other group or earlier. So that could definitely be one of the reasons for the null findings. But yeah, absolutely, you're right that light is the primary time giver to the clock. And so if you're having people get up earlier in that group on average and being exposed to light earlier on average, that could certainly be a driver of the null findings for sure. It's a really good point. Yeah. Okay, and then per actigraphy, again, there's no group differences. I do want to mention that when I think about clinical relevance, I think thinking about our patients who are night owls and they can't fall asleep on time. This is a 90-minute advance of sleep onset time, and I think that's really got to be clinically significant for our patients who are struggling to fall asleep on time. Very impactful, I think. So this was nice to see, and then about an hour-ish shift in when they were awaking. So I think clinically significant for this population on actigraphy, but again, not different by condition. And then everyone shifted towards morningness in terms of chronotype on the morningness evenness questionnaire. Although I will note, I guess this is the one area where we didn't see any change for either group really is, in fact, we saw a little bit of a worsening, not statistically significant, but sleep quality remained poor at both time points for both groups. And then in terms of the side effects or the treatment emergent adverse events, these are very consistent with what you see in the literature with melatonin. So sleepiness, headaches, insomnia, things like that. No serious adverse events. And then to the point that Dr. Arnott raised earlier, which is the accuracy of our paradigm that we use to estimate DOMO versus the actual DOMO. So we had those data, and I think the results are interesting. So it is a fairly standard estimate to think about DOMO being 2 hours before the average sleep onset time per actigraphy, right? So when we estimate DOMO across the sample, it's 20, almost 12:30. When you look at the measured DOMO, actually it was quite earlier, almost 2300. So I wondered a bit, right? So it's almost a 2-hour difference here. I wondered a bit about our sample, who were mostly college students, and whether they had maybe a behaviorally induced late sleep wake phase disorder where they were staying up late to study, to do homework, but they were staying up later than their circadian clock wanted them to, probably, right? If we think about a healthy interval between when your brain starts to release melatonin and when you go to bed, there would be more time than what we were seeing in this sample. So I just wonder if there were some differences in the sample because of the nature of college students and that they were maybe staying up behaviorally as opposed to staying up because their clock was telling them to. So now we get to the possible reasons for the null findings, which I think we've touched on a bit already. So first, it could definitely be that a lot of the shared aspects of the protocol are really what drove the outcomes. So everyone had their time in bed schedule closely regulated. Everyone had their time in bed schedule advanced. Everyone knew that we were closely monitoring their adherence to the protocol. As Brad had mentioned, everyone got, well, I guess in terms of light, we'll talk more about the morning light, but in the evening, everyone was instructed to be in dim light starting an hour before bed. So that might be particularly impactful in this disorder to do that. And everyone did that. And then also, as we were talking about earlier, to Brad's point, that the eDOMO participants may have had more exposure to morning light because they had a greater advance of their wake time in that first week of treatment. And that could have influenced the timing of their melatonin onset. And then also they had a greater advance of their melatonin time from the first to the second week of treatment. So there were some differences there. And then finally, to Ron's point, this study could absolutely be underpowered to detect significant between group differences. This was really a pilot trial. I do mention here that if we consider our findings in the larger context of the existing literature, we see comparable results. So there was a meta-analysis. I think this is the most recent one. I have to see if there have been any updated ones, but 2010, looking at other studies of melatonin treatment for this population. Again, not a lot of trials, but essentially the phase advance that we saw was comparable to those in the meta-analysis, as was the advance of the sleep onset time. Actually, I would argue we had a better, larger advance than what they found in the meta-analysis. So relatively comparable findings. And then in terms of limitations, as Naresh mentioned, we don't have a placebo, so there's no control group for the melatonin. Our sample was drawn largely from the community, so this might look very different if you're only enrolling patients who are presenting to sleep clinics. This was probably a different sample from that group. We had a small sample size, and there were certainly less tightly controlled aspects of the protocol that were meant to maintain like clinical relevancy, if you will, of the protocol, that clinicians could use their own judgment in administering aspects of the treatment. Just summary of the findings. So overall, I would say we observed a large shift in DILMO across the groups, with a corresponding large advance in sleep onset and offset times. So in conjunction with these behavioral interventions that we did with these people, the low dose melatonin time to either measuring the DOMO or the sleep onset time per actigraphy can produce improvements in the circadian parameters that are most relevant to quality of life in this population. And with next steps being a larger scale trial, I think post-treatment follow-up would be important, because I find clinically that you can get a patient here where they're going to bed earlier and waking up earlier for a bit of time, but then, what happens? They go away, they're done with treatment. I don't know if they're maintaining those gains over time. So that would be important to know. Certainly, Niraj, as you alluded to, like a dismantling study where we can take a look at like what are the key ingredients here. Digital based, I think this would be like a really good treatment for an app that people could use to treat this without having to see a clinician, because you can get melatonin over the counter. So in conjunction with wearable data, for example. And then we do have a current R21 that's testing essentially the eDILMO protocol in adults with bipolar disorder who are night owls. So we're carrying the protocol onto a different population to see how it works for them. And that one is placebo controlled. So only one group is getting the melatonin in that trial. So I guess we can see some things there against placebo. And then just some take home clinical messages again, but noting that like these findings are very preliminary. It's a very small sample, but I do think overall we can say that these findings suggest that continuation of the current clinical treatment guidelines, which is the small dose of melatonin 5 hours before sleep onset, works, and that we can have similar outcomes without requiring the intensive DILMO assessment protocol, because that is expensive. It's not clinically indicated or clinically used, and it's quite intensive for the patient. I think we can also take home the message that strict time in bed scheduling, and if you're following up very closely with a participant or a patient, that's going to be helpful in terms of enhancing treatment outcomes, and monitoring adherence can help in that regard as well, potentially. And then I just give you the citation for where our findings have been published in the Journal of Clinical Sleep Medicine. And then acknowledge the funder, our collaborators, many of whom are at the Sleep Disorder Center affiliated, and then the study staff. Okay, questions?
Thanks so much, Leslie. I think there's a number of questions. I think Punitha dropped one in the chat, and then there are a few hands up as well.
Okay. Okay, so beneath is about any particular type of melatonin used as different formulary has different absorption. Yeah, that's a good question. So I think if the type that we used was just a standard like fast dissolved tablet, but there are some that have extended release melatonin, and I think clinically that can be challenging because you don't want someone to have melatonin in their system, like in the part of the phase response curve where it would delay them. But so I think generally I just try to stick to like the plain vanilla clinically. But we studied just again plain vanilla low dose of melatonin in a fast dissolved tablet. And then Xingyang.
Yeah, hi. Well, thanks for the presentation. I'm just wondering, is there any follow-ups with those participants to see if those the effect from melatonin are actually long-lasting?
Yeah, so I definitely think that's one of the limitations of the literature and this study is that we didn't follow participants to see how they were doing, 3-6 months down the road. We did send a survey to these participants a few months later just to see were they still taking melatonin, what were they doing, and I think a fair number of them were still using melatonin on their own. I can't remember what those numbers are exactly, but we did follow up with them just to see, like naturalistically speaking, what they were doing. But that's certainly something that these types of trials need to do is follow people longer than the immediate post treatment.
Thank you.
Niraj?
Leslie, I have a question that I don't know the answer to among many questions, but is the ratio of change in Dilmo is 1-to-1 in the effect size or outcome size of ability to fall asleep, or is it different?
Oh, yeah, that's a really good question. I don't know that that's been studied. I don't know that that's been studied. I need to go look at the literature actually, because I think that's a really important question. I don't think it's 1-to-1 necessarily, because there are trials where they show a shift in Dilmo and people are, so yeah, actually now that I'm thinking this through, there are trials that show a shift in Dilmo, but not a corresponding shift in sleep onset time necessarily. And some, again, it's like a small literature and the results are mixed, but I don't think it's a 1-to-1.
Yeah, even in
Yeah.
your study, I think the Dilmo moved more, but the onset latency was less on
Yes.
the Dilmo side. So I think the relationship is kind of more so reciprocal, not proportionate, I think.
Yeah, I think that's right. Yeah, and I think it's probably complicated and behaviorally influenced, and all those other things. But yeah, I agree. It's not a 1-to-1. You're right. Ron?
Yeah, two parts. The 5-hour recommendation, 5 hours before their current sleep
Mm-hmm.
target, and then you keep moving it as they.
Yeah, so it's 5 hours based on current habitual sleep onset time. So when are they currently falling asleep now? Diary actigraphy, that would be the time at which you derive the initial 5 hours.
Right, and then you have to ratchet it as you're moving
Yeah.
them back.
And then as you're moving it, you adjust everything like time in bed, melatonin time gets adjusted week to week.
And my second thing is what you need, my 2 cents, what you need to propose is a big multi-center trial and have people randomly assigned to take their melatonin at all kinds of times prior to bedtime.
Right. Yeah. I like that.
1
Yeah.
hour, 2 hour, 3 hour, 4 hour, 5 hour, 6 hour, and then do the Dilmos, collect that data at the same time. And then, clarify for us, because what you're saying is that we might have a lot more, we might have similar impact in a range of times that we hadn't suspected.
Yes, I think that's what these data suggest. And again, it might be the clinical versus lab difference, right? But I agree, the only way to do it is, as you said, you have this massive trial and you, have many different options for when people are assigned to take the melatonin.
It sounds like your next PCORI application.
You're the second person to tell me that that's where to take these prelim data, Ron. So I think that's
Well, don't go
I
by
appreciate that.
me, because my success rate with PCORI is not putting me in a position to recommend it to anyone else, but yours seems like a good fit.
Thanks. I appreciate that feedback, Ron.
Leslie, just a comment, and I'm not sure whether I'm stating is right or not. Is college population the right population to look into this? Because some of them may be just innately delayed. And I don't know whether I would call them a disorder or not. They may not be able to go to class on time, and that becomes a
Right.
disorder. But should you look at a different population or?
Yeah, I think that's a challenging question with this disorder, because it does tend to affect younger adults, right? And so most of them do tend to be college students. If we think about the age distribution, it tends to impact the adolescent/young adult population most commonly. And I think that's one of the reasons why we had a younger sample, is because this does tend to impact the younger people more frequently than older adults. But I do think it's where a larger scale trial would be helpful, because you'd have a range of ages, but also, younger adults who maybe aren't college students as well. Yeah, definitely could have impacted the findings.
Great, thanks so much, Leslie. Any other
Thank you.
questions for Leslie?
I was just going to recognize the challenge of running such a study, but also the high clinical salience of the project. I mean, we've always wondered if we had access to people's actual physiology, whether or not our treatments would do better. And so this is really one of the few studies that's really directly addressed that question head on. So congratulations.
Thank you.
And we should congratulate the leadership of the American Academy of Sleep Medicine
Yes.
Foundation, whoever it was at the time,
I wonder
for
who that could
granting
be.
you this award, because it turned out really well.
Amazing vision. Great vision
Yes.
from that leader.
I wonder who that could be, but yes, I'm definitely grateful to the Academy for funding it.
I had to abstain from voting, so the science spoke for itself.
There you go. Thank you.
Awesome. Well, thanks, Leslie. That was fantastic.
Thanks, everyone. Have a good day.
That's the Michigan difference at work.